So, good afternoon, everybody. As we all say, it's a pleasure to be here and an honor. What I intend to do is, I view this really as a workshop, okay? So the idea is to have a dialogue with you and follow your lead after presenting, well, certain highlights on the experience of a clinician in the field using cannabis. My name is Jonathan Grunfeld. I'm a neurologist by training.
May I ask you to use the mic because it's recording?
Okay. I was simply asked not to speak up too loud because of the problems of the noise going through these walls, but it's fine with me. So in any case, I'll repeat, we're doing a workshop basically. And as I said, my name is Jonathan Grunfeld. I'm a neurologist by training. Subsequently, I had some training, a fellowship in neuro-oncology. For over 10 years, I've been doing palliative care, primarily in the field of oncology, but I have seen some other patients in different contexts as well, as one could expect, as I am a trained neurologist. No, I would like, first of all, to highlight some of the issues with which we are confronted in the field as physicians who, for some reason or another, think it's a reasonable idea to use cannabis to alleviate various symptoms. Just a moment, I'll get a hold of this. So, first of all, I want to start with an example which can illustrate some of the difficulties we have orienting towards the implementation of cannabis as a means of therapy, of treatment in the standard world of institutional medicine. And there's an example, one of the issues we deal with, which is a good example, has to do with cancer-related cachexia. Why so? Because in this case, as opposed to many other cases, we have at least one single attempt at performing a clinical trial, a randomized trial in a well-established manner. It was published in 2006. And they wanted to evaluate the effect after they became aware of the fact that there is some supportive preliminary data on the effect of cannabinoids in cachexia. What they were referring to most of all were primarily previous experience with marinol, that is THC. Cannabis and THC are not identical. I imagine that by now, after these couple of days, and perhaps even before that, we're all well aware of the difference. So they planned a rigorously designed randomized controlled trial to evaluate the hypothesis that cannabis can improve the appetite, first of all, and have a beneficial effect on quality of life as well. And they included patients with incurable advanced cancer and an involuntary weight loss that is compatible with diagnosis of cachexia, and notably a very short prognosed life expectancy, which is significant, okay, because we know that can affect the patient selection and subsequently the outcome. Okay, the performance status was also relatively low, 2 or below, as it was not considered for people who were still reasonably functioning. And they administered extracts of cannabis, either containing THC alone or combined THC with CBD or placebo. And at a relatively, one standard dose for each one of those combinations, 2.5 milligrams of THC with or without 1 milligram of CBD 3 times a day. And they followed the patients essentially for a month and a half. And the outcome measures were a visual analog scale assessment of appetite and a standardized score of quality of life. And this trial was discontinued early because already during the interim analysis it turned out that there was no difference between the groups. Okay? And the accompanying committee decided to discontinue the trial. And since then, we haven't had any other trials. We haven't had a critique of the findings of this trial. And on the other hand, I will present a letter that I received spontaneously from a patient of mine. Now, basically, I'm not representing all the experience. In terms of numbers, where I come from and what I represent is an experience with circa, let's say, 2,000 patients receiving cannabis, who I personally have supervised over the last 5 years or so, 5, 6 years. But this, all the data from all these interventions has not been organized for various reasons. That is something that can be discussed later on. But there is a major issue organizing data on cannabis when the intervention is not standardized, you're using different preparations, different medical conditions, etc., etc., a very various population. In any case, quite frequently, not always by all means, but quite frequently you get dramatic responses to cannabis in the context of palliative care. And this is an example. So he sent this letter to me, and he wrote, this is originally in Hebrew because that's where I come from Israel. He wrote, 2 months ago I started feeling pain in the side of my body. The pain was accompanied by a loss of appetite and severe nausea. Just about every attempt to eat resulted in vomiting. Now, this letter is translated word for word, okay? I'm not interjecting any ideas, any opinions, any observations of my own. That is the reason I'm presenting it here. A comprehensive workup, he writes, discovered a malignant tumor in the liver. And now, at the moment, I added now, yeah, I am being treated with pills for the pain. The pills also cause severe nausea and constipation, for which I am receiving an anti-nausea pill and a laxative, which unfortunately are not helping. And all I feel is fatigue and poor concentration and lack of interest. A strong urge to sleep all the time and a very low down mood. New paragraph. I wish to point out that until now, the only thing that made me feel much better was the use of cannabis. Physically, the body is less tense and less painful. The appetite increases, and I can eat anything without feeling full and choked up. I do not vomit at all. The mood and general feeling are much better without nausea or side effects. And his conclusion, voluntarily offered by him, was, the way I see it, the difference between the feelings with cannabis and without it is the difference between heaven and earth. That's an expression in Hebrew. Okay. And I guess the intention is clear. So, on the one hand, we have a rigorous study of cannabis for cachexia with a negative result. It was done the way we have to perform clinical studies. On the other hand, we have this report, and perhaps another one, and and another one. But one is enough to bring to the surface the question, how can a physician confront a patient describing such a dramatic response, and I mean, how should he respond to that? Should he say, okay, I accept this description and I think that is reason enough to recommend a trial with cannabis despite the lack of any well-established scientific data? Or should I ignore this information, say it is not valid, and continue managing patients who have no alternative beneficial intervention at their disposal? There's nothing else that can help them with this situation. They'll keep on getting the morphine with the constipation and the nausea and feeling poorly in general and staying in bed, and will not be able to describe what this patient has described. So what do you think? Where do you stand? This, I think, is one of the issues that really touches on the point, because doctors do not feel comfortable prescribing or recommending the use of cannabis. And then you have this patient, and you have another patient who comes along and says, look, doctor, I know you are not from the drug control, you're not from the Ministry of Internal Security or whatever. I have used cannabis, and it really transformed my life. When I took it, it was the first time that it was free of vomiting in months. And these are descriptions that I see. I receive such inputs from patients arriving in my office. Now, how should I respond? I don't know. What do you think about that?
Can I just ask, was the patient that wrote the letter, were the doses of opiates reduced after he or she started receiving cannabis?
Yes.
Because, I mean, that could be a methodological difference between the two studies, because obviously part of the problem could have been caused by opiates rather than, you know what I mean? So if in the study they didn't decrease the normal medication, that could explain the difference between the outcomes. Now, I haven't read the paper, so I don't know, but that would be my suggestion. So in that case, I would obviously see the two cases as very different methodologically.
Yeah, well, obviously there is a methodological difference, but what I'm trying to point out is that there is actually a difference in approach behind this, okay? Because I'm confronted with a patient who provides me with apparent primary data, already verified that the cannabis is helpful for him, and usually these patients are rejected or ejected from the clinician's office saying, this is not a place to get cannabis, we are not drug dealers, full stop. And we are committed as physicians to help these patients. Now, I wonder how you feel about it. And if a patient like that would turn up in your office, if you are physicians, or would be under your care, how would you respond? I mean, how many would be in favor of authorizing cannabis for such a patient? Okay, so you say it's a no-brainer. But still there are some people here who are, you simply don't take care of patients, is that the issue? Or you have your hesitations about treating a patient under contemporary conditions? Obviously, if we would have more data, we could decide if there's something better to offer or how to go about it. But as things stand now, this is the option that we have. This is the option the patient has. So, that went back. Okay, so there is this discrepancy, and there are doctors and there are patients, and there is some kind of interface between them. And the doctor, unfortunately, is sandwiched somewhere between his commitments to the patient and his commitments to the medical institution, medical establishment, the regulatory powers that be, who monitor him and dictate all kinds of things. and possibly he is legally minded as well and doing his best to avoid any indictments. So there are various forms of seeing a doctor. Sometimes, I try to find images of patients with cancer, and they were all smiling, of course, very pleasant pictures. This one wasn't smiling anymore, and the only place I've succeeded in seeing a patient who is suffering is when they wanted to warn people against cigarettes. So there is this encounter, and I think a crucial point in applying cannabis as a treatment for palliative care patients is the interface between the doctor. The primary issue is actually not the science at this point, the science behind the use of cannabis, for example. Just as the management of patients with pain, providing other pain analgesics, including opioids, is a minor part of the management in palliative care, from my perspective at least. You have to establish a contact, a rapport with the patient and everything, and then there is this technical issue of giving him 5 or 10 or however many milligrams of this or that preparation, and it will work. So in this interface, what happens commonly is some kind of discourse, and this I try to represent a stereotype meeting between the patient who comes demanding or requesting cannabis and the doctor in front of him. And the patient comes and the doctor says there's no scientific evidence. And the patient says, but it works for me. The doctor does not feel comfortable. And these are things that happen in reality in Israel, okay, where we have the authority to at least recommend the cannabis. I personally have the authority to issue the licenses as well, which gave me a lot of leeway and enabled me to gain a lot of the clinical hands-on experience. But the patient comes and says it works for me, and the doctor tries to dissuade the patient. He says cannabis can cause you harm, can do all kinds of bad things. I've had patients come to me from other institutions reporting that their mother, not the patient even, the patient was too ill. She was at home, lying in bed, incapacitated by metastatic breast cancer, and her son comes along and says, well, the doctor told her, he said, well, do you want the cannabis to harm your brain? You know, it's possible that it can cause some harm to the brain cells, and things like that, which I doubt the doctor believed, but it was just another way of convincing the patient that he is not interested in supporting any use of cannabis to alleviate the pain and other symptoms. So he says, cannabis can cause you harm, and the patient is no fool. He says, yeah, but so can other drugs. And they often point out how many difficulties they have with the opioids, for example, with all the side effects that whoever works in palliative care is well acquainted with. And, they say, the doctor says, but still, these other drugs, maybe they have side effects, but they've been tested. We're using them in a scientific way. Okay, we have the data. We know that we are causing these and these problems, but we have data, so we can tell him that the chances that they will develop constipation are so and so many %, let us say, in a good case. And all the other drugs all have remarkable side effects. I mean, steroids is an outstanding example. Okay, so you help the patient not vomit, but then he can't sleep through all the night, and he's irritated and fighting with everybody around him, not being able to withhold his outbursts of anger and despair, or just becomes depressed. And the patient says the same. He says, but still, these other medications, for which you have all these scientific data, they cause more harm than cannabis. Doctor, of course, has his authority, and he insists that the patients should not just listen to lay opinions, because many of the patients come in with recommendations or experience from their neighborhood. You know, they are not necessarily grown up to listen only to doctors. They say, yeah, but my neighbor had a fentanyl patch, my neighbor had a puff of cannabis, and that's what helped them. And the doctor can listen, it's no shame. And if they look something up on the internet, so much the better. Okay, they're involved in their treatment. There'll be less problems with what they call nowadays adherence to the recommendations. They'll comply if it makes sense to them. Okay, and then after that, the patient will say, I don't know, but still, I feel good after taking the cannabis. Is that legitimate? The doctor thinks it is not all that legitimate. And I've had patients come in and report that the doctor told them things that are more or less like, you know, of course you feel good. That's exactly why you want me to prescribe the cannabis to begin with. And then of course you wonder, why are they prescribing escitalopram? Why are they prescribing benzodiazepines? Is that to make the patient feel poorly? Obviously not. And the patient says that. He says, still, I cannot see what's wrong with that. And then comes the moment, if the doctor cannot get the patient out of the office with all these excuses, he may become violent. He simply tells the patient, no matter what, this is not a point for distribution of drugs, and will you please leave my office? And that's it. And the doctor is frustrated. The patient is also frustrated, and he remains without any treatment at his disposal. So, and obviously we can see that I think the major issue the doctors have are not scientific. They are not scientifically established. They say, we do not recommend cannabis because they have a feel of some kind of discomfort. I don't know how you perceive it, and it's interesting for me to hear if that is your perception as well.
In France, we are in front of a different problem. There are also people like that. I'm not a drug dealer, and we were confronted with that also with buprenorphine and methadone experience. It was exactly the same argument, exactly perfectly explained there. And with cannabis now, we have some doctors like that. But we have also a lot of doctors, including in oncology, a lot of specialists, who say, now we are off. I'm not doctor, you're not patient, but I recommend you the use of cannabis. Speak with your son and find some. Mm-hmm. But I don't want to give you a prescription. And now with the new European system, a French doctor can make a prescription of Bedrocan, for example, but they don't want to do it because I'm not a drug dealer. But go to the drug dealer, it's good for you. This is exactly the paradox we have in France now. Some even big specialists of oncology are for the use of medical cannabis because of all the testimonies, but they don't take any risk to help the patient to have the medicine, and they don't want to make prescriptions.
It will taint their prestige, their professional prestige, something of the sort. Is it? Yes.
I thank you very much for your really interesting introduction, and I recognized in that this way of argumenting we sometimes use, even if I think, I'm speaking from Czech Republic experience, my feeling is that what is the issue now, really nowadays, are that the officially and legally prescribed cannabis is much more expensive for the patient than those if he buys it in the street. So, and it's my experience, I'm a palliative care consultant, so we have the legal rules how to prescribe it legally, how to obtain it in the pharmacy, how to use it. but it's 3 times more expensive than if he buys the joints the comparable amount. Even obviously what he buys in the street, it's not, well, we don't know the composition, the content of the components is not known, but in principle what I resolve is this cost issue. And this is what sometimes hinders me to recommend the medicine. I really appreciate when you share, or if you share with us your experience with 2,000 patients. So I have the experience with some 20 patients, but my experience is that it's not a panacea, it's not a treatment for all problems of advanced cancer patients. And the issue is, and it's perhaps the scientific question, just how to recognize the patient who would benefit from it. And it would be perhaps my question, if I can ask, in pain management or in symptom management, we often speak about this so-called number needed to treat. That means how many patients do you have to treat to achieve the really clinically meaningful
NNT,
benefit,
yeah.
NNT. So according to your experience with these 2,000 cannabis-treated patients, what is the NNT, palliative, meaningful benefit?
It's difficult to tell, of course. First, because I don't have the data recorded, so it would be just a very crude assessment. The second thing is that there is a great assortment of symptoms which respond to cannabis, despite the fact, the obvious fact, that it is not a panacea. But it does impact a broad spectrum of symptoms, which makes it actually ideal for use, especially in palliative care. And on top of that, the context of palliative care is much less demanding in terms of scientific establishment of the efficacy and so on. I mean, we can titrate the treatment to the response of the patient, and we rely on that. Actually, we do it with other drugs as well, but the context of palliative care is obviously very useful for that. I'll just move on because, yeah.
You mentioned the costs being very high here. Today, when producing large amounts of medical cannabis, the price is very much cheaper than the street value. In Israel, we provide patients with $2, that's 1.5 euros a gram. And here, Bedrocan has monopolized on the import. They import cannabis at 9 euros a gram, which is 3 euros above the market. And when they go to the tenders, they underbid everyone at 2 euros a gram to beat the market. So obviously they can grow it for cheap, but they choose to overprice it. Why? I do not know, but they do that, and that's why the medicine here is expensive. But once the government here regulates growing, the price of cannabis should not be more than 2 to 3 euros a gram. And at that point, it gives doctors the freedom of being able to prescribe and treat patients. And the problem isn't necessarily with the cost of cannabis. It's the people growing it wanting to monopolize and make a lot of money, charging 9 euros a gram in... Because it's brought from Bedrocan. Yeah, because Bedrocan sells it for 9 euros. We brought the cannabis in. We bought it for 9 from Bedrocan, brought it here. The taxes and the transportation brought it to 11, and we put it in the pharmacy with no profit. So we didn't make anything. Bedrocan made 9 euros, and it's expensive. And when we want to grow it here, we should be able to grow it. They could grow it in Bedrocan for cheaper, but they choose to ask for an exorbitant amount of money. And it's also the reason why they went down from 4,000 patients to 1,200 patients in Holland, because they want very high prices. In Israel, the prices don't go above $2. That's $1.50 euros, 150 euros a gram, and that's affordable, and that's good care.
Yeah. There are two things at least that I should mention. One, that I skipped over the disclosures, and this meeting is sponsored by Better, okay? And I have also provided some lectures for Pfizer sometime a long while ago, and I am associated with another company that is also involved in sort of apparatus for cannabis, but I have no formal association with them. The second thing is, as far as costs are concerned, you know, this is really taking the role of the doctor a bit beyond, because we are concerned not just in finding out what is appropriate for the patient, we also want to make sure that he can receive what we recommend, and that to increase the chances that he will stick to it. So I don't know how the system works here in Czech, but patients spend money on other medications as well. And many of these medications are spared once they start using cannabis. I can give you some examples that can bring us over into another context as well. One of my patients, gastrointestinal cancer, and on top of that, severe cervical stenosis. He's suffering of pain, no doubt. Unfortunately, he was a drug addict many years ago. And he has the whole habitus of a drug addict. Okay? When I first saw him, he was taking 180 milligrams of oxycodone every day. He was locked up at home, had a poor relationship with his female partner, was not going out to see people, was not working, nothing. Smoking a lot of cigarettes, something like 2 packs a day. Today, he uses cannabis. He doesn't touch oxycodone, this so-called drug addict. He was, through and through, a classic drug addict. He does not use 1 milligram of opioids. He stopped smoking. He's getting along better with his female partner. He leaves his house, walks outside, and does an occasional job here and there. Now, you know, this has something to do with the whole process of introducing cannabis into treatment by partnering with a patient. And that is actually something that I thought of sparing for the next session I have. So maybe I will spare it. Otherwise I won't have anything to say. In any case, there is an issue of negotiating with the patient. And I think this is another aspect that we have to take into consideration, really the connection between the doctor and the patient. Once we send the patient off and tell the patient that we are not drug dealers, we are disrespecting the patient, and we obviously do not trust him. The patient, on the other hand, has no reason to respect us, and obviously not to trust us. It goes even further than that, because what actually happens is that these patients become alienated from professional doctors, because they know from their own experience what does good for them. They know it, and the doctor does apparently not know it, or will not behave accordingly. And then the patient says, well, you know, this doctor, he doesn't know anything. I cannot rely on him. I know what is good for me. I have experienced it. The mistrust that you have there is the core of failure in palliative care or whatever. This is the essence of palliative care. Okay? So mutual trust and respect are definitely fundamental. And they also enable the clinical use of cannabis, and that's how I got into it to begin with, because I had no ideology regarding cannabis one way or the other. I was a neurologist, and I encountered a patient who was not a cancer patient, who had taken cannabis, and his life was transformed within a day. He was a stroke patient. He had spasticity, he had pain, he had consecutive panic attacks. Okay? He received the cannabis, and the next day his wife blessed me on the telephone. I did not call her up and to ask her how he's doing. She called up on her initiative, called me and said, this is wonderful. I haven't seen him like in this form in years. And he has been continuously taking it for 6 years already and has a relatively better life after having failed 18 different psychiatric drugs, drug regimens to manage his panic attacks. This also brings another issue to mind. And that is also why I mentioned the drug addict before. Because we have certain rules about whom to prescribe and how to prescribe. And the normal thing would be drug addicts. If someone ever was a drug addict, he's not going to get a permit for cannabis. He's illegible up front. He is not going to get the cannabis. Those are the rules. And the same with anxiety. If someone has panic attacks, they would say anybody who with a history of panic attacks will not receive cannabis because this is a likely side effect of cannabis and you don't want to make his situation more difficult. But when you collaborate with the patient and you have trust and you know that generally speaking the effect is transient and not organically damaging, you give him the chance and you observe a benefit. So it is not scientific, but we have alternatives. As we said before, we can either abandon the patient or do something that is not exactly in line with our professional code as it is formulated by the establishment. And you know, I'm a clinician, as I said, and what I rely on is really the direct titration of the symptoms of the patient in a face-to-face encounter. And it is effective. It is effective not only in that letter. In the case of the patient who sent me that letter, it is effective across the board. Some of the patients discover that it is not useful for them, and they don't continue using it. I mean, the key factor that enables us to use cannabis in this form is that it really has ultimately a very safe profile. It is true that people can become uncoordinated and confused, and they can be stoned and lie in bed. You know, there is a report of an overdose of a lady. It was reported in a journal of palliative care, I think, but I'm not sure. By Van Hasselt is the name of the report, the clinician who reported it. Reports a daughter who treated her mother with cannabis extract. The mother was with lung cancer in Holland, and the daughter went out and got this concentrate for the mother. And the mother received a high dose, and she was stoned. She just lay there and couldn't talk or do much. Now, in the report, she's described to be in a coma. She was brought to the hospital. Her blood pressure was normal. Her temperature was normal. She was slightly tachycardic. 100. She didn't get over 110. And she was discharged the next day from the hospital on her feet without any damage whatsoever. Okay? But she is still reported as a severe adverse event. She was in a coma. The concentration they found in her serum was about 100 times the concentration that is believed to be the threshold for high, for a psychotropic effect. So 100-fold overdose. And she walked out of the hospital safe, on her own feet, without any damage, within 24 hours. Now, this was presented in the literature as an example of the dangers that we have with using cannabis. Depends on your point of view. On the other hand, show me another drug that you can overdose by 100-fold and have the people walk out of the hospital within 24 hours. Yes, definitely.
Because the scenario that you're presenting is that the obstacle is mainly with the doctors, that the doctors are reluctant to recommend or to prescribe. But do you have any experience with the opposite scenario, that you offer cannabis to a patient, but they say, oh, but are you a drug dealer or are you a charlatan? Why are you offering me some herbal therapy? I don't trust you. Because the fact of the trust, I mean, it can work both ways, where even if you are convinced that this is going to help, or it can help the patient may actually lose trust because you're offering something that doesn't really look scientifically solid. So do you have an experience with that?
Definitely. Well, we have a slight advantage in Israel because there's a lot of publicity for medical use of cannabis nowadays. Still, many people are wary of it and will not approach it. And that has to do with really the hands-on experience, how to deal with it vis-a-vis the patient. And there is an issue with what is known as nocebo. Nocebo is a concept which is, interestingly, is not well known to doctors. Doctors know all about placebo. When you say nocebo, then the doctors say, well, I haven't heard that concept in medical school. Nocebo is just the inverse. Okay, you give someone a pseudo drug, which is supposed to be associated with all kinds of adverse events, and they become, and these individuals who receive this non-drug containing preparation manifest these adverse events, and this happens with cannabis as well. So we have the inverse. Generally, negotiating the whole issue of cannabis with the patients really has to do with that statement, you know, cannabis is not a panacea, and we have to sort of manage ourselves between extremes because expectations may go very high, and that, of course, leads us to disappointment. And I have had patients return to me and saying, I'm very disappointed. And then I ask them, how come? They say, well, I say, but look, before you were taking such an amount of opioids, now you're taking half, right? He says, yeah. And now you are sleeping through the night. Before that, you were not sleeping through the night. True. And yet you are disappointed. And then they say, yeah, but I expected more than that. Okay? So we have to prepare these patients to explain that, you know, it has benefits, but we live in reality. It's not going to blast you out into a different reality and make you 18 years old and healthy. It's interesting, you know, one of the experiences with all these patients is that cannabis has a very interesting way of affecting the patients. It sort of detours perception. So you really can have people taking cannabis, everybody around can tell that they're doing better, but they are not aware of it. Somehow they do not become aware of the effect that cannabis has on them until other people remark on it. I cannot explain it, but it is a consistent observation. I hope you will have your own experience one day, if you don't have yet.
I have a question. If it's taking you too much out, so go on. How much you have pressure from the hospital to give or not to give a prescription? And that's one question. And second, how you're afraid from side effect, mainly with chemotherapy, if it's interfere or not interfere with the chemotherapy?
with chemotherapy, look, we are dealing primarily with palliative care patients. Often it is quite questionable to provide these patients with chemotherapy to begin with. It is just sort of a last stand because the doctors don't know how to face their patients and discuss their plight. And then they say, well, we'll just go on treating because we're going to save you. And the patients say, well, you know, will I be healed? And the doctor sort of hesitates. And that is the context of palliative care. So the issue, I mean, to maximize the effect of a drug, essentially we are not aware of such problems. Where I have encountered problems with cannabis is something that most people are not aware of. Cannabis is a MAO inhibitor, okay? It inhibits reuptake of monoamines. Obviously, you would not want to give it with all kinds of SSRIs. And the way that I became aware of that is that I had an elderly patient, and another patient, and another patient, who had a sort of paradoxical response to cannabis. You know, the same species that usually was effective, all of a sudden made them agitated. And somehow I decided to decrease the antidepressant dosage, and they recovered. These are not frequent occurrences, and these are not occurrences that have been reported. But there is a logic to a physiological logic to it, and I think it is something to take care. So I personally am quite wary of providing high doses of cannabis together with SSRIs or SNRIs. I try to avoid it, and when I do, I am with my hands-on following the patient very intensely, and if I have any suggestion that they're responding in that manner, then I decrease the dose of the SNRIs. I must say that in the context of palliative care, in Israel at least, there is a very loose approach to the use of SSRIs and SNRIs. You know, the patient, the doctor sees the patient and feels uncomfortable, and then provides the patient the drug to soothe himself, in a sense, because you know they don't wait to control the pain and then give the SSRI. Often, if patients are suffering of pain or other symptoms, they will appear to an untrained eye as depressed, but they are not. They're simply suffering, and if you alleviate the suffering, then they'll be perfectly normal in terms of their mood fluctuations. So there is this, you know, the doctors adhere to the concept of evidence-based medicine. That is, you know, it's always a very handy sort of argument. They say, no, there's no science to it. But the point is that evidence-based medicine is constantly being misinterpreted by the public, of the doctors. I mean, we are all aware of it. Most of the therapies we have to offer, most of the clinical decisions we make are not necessarily based on randomized controlled double-blind studies, because there are so many variations in the circumstances, and only a few of those patients would have even been included in such trials had they been performed according to the inclusion-exclusion criteria. And the specialists who deal with evidence-based medicine, even to begin with, saw the component of information coming from such trials only as one element in their considerations. You have your personal experience, you have the patient feedback, you have the expertise, you have some knowledge of the physiology and the pharmacology. These schemes all come in and combine to help you arrive at a decision. But those doctors who are legally bent and so on, they say, look, these are the guidelines, and every guideline I am aware of in evidence-based medicine says, ultimately, these are just recommendations, but the physician in the field should make his own decision. But that last sentence is often disregarded by those who argue, let's say, against the use of cannabis. They'll say there are no randomized, there's no scientific evidence, and they will abandon, throw out the baby with the bathwater, so to speak, instead of accumulating more clinical experience and then improving it as they move along. I'm going backwards and forwards all the time for some odd reason. Okay, and here are some question marks that I have. So how can we deal with these claims regarding the medical utility? I'm still sticking to that question. And I have repeated myself several times concerning the abandoning the use of cannabis or identifying alternative sources of legitimacy. And I think that the position that the doctor takes vis-a-vis the patient can guide him in his decision. I conclude here with another letter from patients, which is instructive in the sense that it suggests the broad spectrum of impact that cannabis has in the context of palliative care. So this is a 65-year-old man who wrote to me of his own will. I came to you in a terrible psychological and physical state after difficult operations entailing the opening of the abdomen and the formation of a gastrointestinal stoma. The side effects were terrible indeed and associated with a very poor quality of life. Among the side effects, this is the way he formulated, okay? So if there are any gaps here that we have to fill in, we can. But in general, he mentions a whole host of side effects, including poor control of the sphincters, some of which were resected in the operation because he had anal cancer. With poor control, fecal incontinence. Of course, he lives in reality, so he was also exposed to a traumatic event of his own son committing suicide, and he had difficulty coping with life due to that event as well. He had eczema on his hands. He used cannabis to rub in on his hands, and that alleviated the eczema, because there are multiple aspects of cannabis in which ways in which it can be implemented to help. He also suffered of diabetes, treated with insulin, and he says, I have gone down to 0 medicines, 0 insulin. Blood tests demonstrate normal glucose values. And he's not the only patient. Okay, so we are not in the position to use cannabis now as a treatment for diabetes. But we have enough raw data to say that if a patient comes and reports an improvement in his metabolic status, it definitely can be associated with the use of cannabis. And here he comes and tells me that. Just last week I had a patient come in with a thymoma and myasthenia gravis, which is an autoimmune disease commonly treated with steroids for very long term. And he was started using cannabis when his hemoglobin A1C levels were about 15 on treatment with steroids. And he still had a remainder of the thymoma, which could not be completely resected. after 3 months, he came back to his doctor, and his doctor did not believe his eyes. He had a hemoglobin A1C of 5.2. He was using half the amount of the steroids and was feeling better for one reason or another with regard to the control of the symptoms of myasthenia. He also reports that the thymoma is somewhat smaller according to the measurements on the imaging. This is anecdotal evidence. It is not something that I'm going to establish a recommendation on to treat all patients with myasthenia gravis and thymomas with cannabis. Okay, but still, I cannot offhand reject his claims, and there is no reason to. I can tell him, well, you know, I cannot tell him that it is not associated with cannabis treatment either. Okay, we simply say that we currently are not at the point to make any well-established recommendations, but we have good reason to continue recommending the cannabis for him and prescribing it for him personally. He also had leg edema, severe edema. Both legs were swollen. Nothing helped. I mean, he got diuretics, got everything. Nothing helped him against the edema. After starting using the cannabis, the edema resolved. Of course, there's this emotional attachment that they have, okay? They attribute to the doctor all kinds of things that actually have been done by the cannabis, okay? Of course, I know that I am a guardian angel, but this is an important element of palliative care, to really establish a rapport with the patients and respect their requests for cannabis if it makes sense to us. And the question really, after all that, is, can you make a list and tell us when yes and when no? Maybe I'll get back to that. Okay, and he says there's not wide enough a canvas to contain all the changes that have occurred to me in all levels, and he wants to translate his gratitude into words, and that's why he wrote this letter. He was not a whole human being in the beginning, and you, he is actually talking to Mr. Cannabis, have returned my life to me. And this is an expression that you hear from many of the palliative care patients. Okay, so it is a very powerful intervention, and it is powerful not because of the intensity of my belief in its efficacy or not, and it is not powerful because of the scientific data or not. It is powerful in each and every case in terms of the transformation of the life of the patients who receive it. He notes that he has turned into an active and dynamic person, brisk and full of energy, losing 22 kilograms of weight. He was overweight, and he lost the edema, and he lost some of his belly. And this also has to do with hesitations people have with prescribing cannabis. Because, first of all, it is common for physicians opposed to the use of cannabis to evoke the whole issue of amotivational syndrome. And the fact is that people who are ill and receive cannabis, it may have something to do with the selection of the species, but still become much, much more active in many senses. As far as the weight loss, you know, they are always concerned with the munchies and the increase in appetite, but people who are overweight tend to lose weight when they're receiving cannabis. Another example, which is outstanding, I think, as far as energy is concerned, has to do with patients receiving chemotherapy. And there are many such patients. And the most prominent side effect of most of these chemotherapeutic regimens is something that we do not know how to describe very clearly. We call it fatigue. People go home and they cannot raise themselves from the chair, from the bed. They cannot do anything. They do not have the power, the energy to do so. And that happens, let's say, with young women receiving chemotherapy for their breast cancer. They have no other disease. It is simply that, and they are functioning mothers, wives, who cannot fulfill their duties or what they perceive as their duties, what they want to do for their family. They cannot go to work, they cannot care for their children, nothing. When they receive cannabis in that context, they keep on working, they keep on tending for their children throughout the chemotherapy, quite often. Am I telling you about a miracle? Possibly some of you have had this experience, but I think I mention it here to emphasize how significant this impact on the energy people have that can be associated with use of cannabis, and contradicts all the reservations doctors have about the abulia syndrome. Okay, and he changed his entire diet, of course. Enormous change for the better, virtually a slight experience of euphoria that decreases to a very minor degree for the regular smoker. Okay. And, well, this is the question that I started with, and I am ending. This is not a scientific session. It is, as far as I understood, it's supposed to be a workshop. And it is has something to do with sharing the experience that I have, which I cannot organize methodically, because I have a great variety of patients of all ages, of many different diseases, receiving all kinds of cannabis preparations. Some of them are improvising on their own. Some of them buy the for example, they buy the flower buds and then extract oil on their own at home. I am not the regulator going to go after them and tell them what to do and what not to do. But this is what happens in reality. I have patients whose children or grandchildren go out to the black market to buy all kinds of cannabinoid preparations of sorts, mingling with an unpleasant social milieu, and spending a lot of money, because in Israel, cannabis, medical cannabis especially, is considered something good and goes for very high prices relatively. So they benefit from receiving the cannabis for a price under the protection, under the auspices of the health ministry. On top of that, they spare the money on some of the medications. Those who smoke cigarettes often discontinue using the cigarettes, and that is one of the ways that I can convince them to move on to using vaporizers, because the vaporizers also cost a lot of money. I say, well, you stop smoking for 2 months and you can buy 3 vaporizers, not just 1. Okay, so these are the petty details which actually constitute the reality of caring for these patients when we are lucky enough to have the freedom to provide cannabis. Another thing that has to do perhaps with that clinical trial that failed is that when you have a fixed dose and a notion of that sort and a selection of patients who are doing very poorly, you do not have the opportunity to treat them when they have more potential to respond to the treatment. And you are not titrating the treatment, because when I treat my patients, I titrate them. Take it. No good, take a little more. No good, take a little more. And there is a variety of species available for use in Israel. So I have had patients using one. First of all, they use different, it is common for them to use at least 2 different species, one for daytime and another to go to sleep at night. And there are different issues. And there are there is a discussion about the significance of species-specific responses to cannabis. Okay. The general experience is that some species will induce more of an appetite, others will be more effective against nausea, other will have a good impact on spasticity, and the patients move from one to another, until they identify the optimal treatment, and then they stick to it. And patients do not like to feel drugged, stoned, or incapacitated by their treatment. That has to do with the respect and the trust. I cannot imagine that people want to cause themselves discomfort and deteriorate functionally. And I have the opportunity to work in such a flexible setting, which is not exactly compatible with the way strict institutional medicine is practiced, but it is more effective. I don't know. You have any remarks, any questions? Yeah.
I have a lot of demands coming in from hospital for the last week of life, with people who are not able anymore to vaporize, to smoke, or to eat. Also, a lot of problem. People with nausea, people with no more need to they don't want to eat. In fact, even if the appetite, they don't want. But they appreciate the effect, the mood, and the control of the pain with cannabis. And in this case, what forms of medicine you use to deliver it to the patient? Because I have a lot of demand coming, even from hospital, because patients arriving with cannabis, and so often it's weed, and the people in the hospital don't know how to deal it when the patient is too sick to vaporize or to smoke. And this is a huge demand.
Yeah. Well, there are several options. First of all, vaporization. Some of the vaporizers have bags which you can use to actively pump the vapor when they are inhaling. Suppositories, oil, which is absorbed sublingually, is used commonly. And often they can smoke as well. It is incredibly effective in the end-of-life phase, which nowadays established medicine, to my knowledge, around the Western cultural sphere, let's say, are receiving a whole lot of opioids towards the end of life. And they sort of gradually sink into a semi-coma, death rattle, absent. We do not know to what extent they are exposed to all kinds of horrifying hallucinations. I remember when I was in the States doing my fellowship, entering the room of a patient who saw me enter the room through a wall of fire. Okay? She was terrified. I had a patient, one of those many patients who do not feel comfortable with our Western medicine, and she had already experienced therapy for her breast cancer in the past. Then she was diagnosed with lung cancer. She didn't even want to have a biopsy because she said up front she's not going to have any chemo. And she insisted on that. Gradually, it became clear that it was a metastatic lung cancer, which progressed, and she was entered into an institution to die, end-of-life care. And she was on cannabinoids. She could not communicate with anyone. On opioids. She could not communicate with anyone. She was just lying there in bed, and they were all just waiting for her to die. And then one of the members of her family came around and provided her, we arranged a license to use cannabis, and they gave her a joint. And she was wheeled out of the room in which she was supposed to die, and had a couple of puffs from the weed outside in the open, and she opened her eyes, and she welcomed her visitors, and she lived on for another week without being groggy, hallucinating, and apparently suffering. And then she passed away more peacefully and without that ugly end-of-life scenario many of us are acquainted with when we use the standard medicine, Western approach. Maybe to conclude, you know, I don't know how, where we stand time-wise. We're done. Okay. So just to conclude, I'll say the overall effect of the cannabis is really what is interesting and intriguing, because you can alleviate one symptom and another and another and another. But when you give cannabis to a patient, you alter his emotional presence, and he, instead of being introverted and focused on his suffering, and this is, you know, it sounds very soft, but it is a concrete experience you see again and again. They open up, the patients, and they become responsive to their social environment. They even are happy to receive guests. What dying palliative care patient is interested in seeing guests? You know, they just do their obligations, but they say, leave me alone, I want my peace. And all of a sudden they interact with the people. And the whole family benefits for it. So you're not just treating the patient, you're treating the whole family with the cannabis. I don't know. That's a way to conclude this, I guess. I don't know. Somewhat biased, but we all have our biases, and I admit them, but the experience is expressed in those letters by those who have received the cannabis. Those are not my words.